So I had this patient. So she's come in the clinic. So initially I assessed her on September 19th, 2022. So it was last year. It's a 53-year-old female patient. Came in for low back pain and left hip pain. Was limping when walking. It was quite evident. The pain started about 5 years ago, and it's been getting worse since. She doesn't experience any pain at night. The only time she experiences pain is when she's walking, when she's bending and lifting from the ground. And the pain is shooting down down the side of the leg, the left leg. Imaging has shown slight arthritis, but it's nothing. Wasn't anything major. And then the biggest problem with her is that because of the fact that she stands all day long, that creates a lot of pain and more suffering. She did go to chiro and it didn't help. I don't know what the chiro did. Probably maybe like a short treatment. Didn't really probably get into the details. RMT helps a little bit and then it kind of gets back to pain. Physiotherapy, when she did go, mostly focused on strengthening exercises and stretching, which kind of made it worse, especially with the strengthening exercises. She found that it just flares up a lot more. Past medical history, she just has high blood pressure meds that she's on. Other than that, she's got nothing else. There we go. So looking at the objective aspect of it, observation, one of the things that I did notice that she's got a little bit more calcaneal eversion on the left more so than the right. When she stands on the left hip, so when she does a single leg stance, that left hip shifts sideways, so shifts out quite a bit when she stands on assist. So essentially the glute muscles, they're not really engaging, and she's just, that hip's just going out. Also, her left ASIS was about 1 inch lower than the right. And also the left PSIS was 1 inch superior to the right. That was based on observation. Also, she was doing quite a bit of limping. The left hip, when I did do the range of motion, the external internal rotation, especially the external rotation, was quite stiff. And it was very, very stiff, so I couldn't really push it too much. And it was painful at end point. Strength of the left hip, when I did put her in, this is basically I got her side lying and I got her to push into my hand. It was about a 3 out of 5. So it was a side lying abduction test. And then special tests. The left Faber was about 32 centimeters off the plinth. So what I did was I got her into that Faber position, into that external rotation, and I measured from the bottom of the knee down to the plinth to see how far she can go down. It was about a 10 centimeter difference from the left and the right. So noticeable stiffness on the left hip. And then I looked for some trigger points. Definitely quite a bit of trigger points in the left glute med, glute max, TFL, psoas, adductors and lumbar erectors, and then also the QL, the left QL. So basically that was my objective. Now what I'm gonna do is give me 1 second here. I'm gonna run the video. So I actually videotaped her walking. There we go. So, and the beauty of getting your phone out and doing these assessments and getting them to walk and seeing how their hips are, I mean, it's unreal. So whenever you guys get a chance, get your phone out and just, record how they're walking, because you can go slow motion. You can really kind of see what's going on. This video here, the way it was put on the computer, it's flipped. So this is the left side and this is the right side. It's a little bit weird the way it kind of came out on the computer. But anyway, so I'm just going to get her to walk. So what do you guys notice? Can anyone give me any ideas? What do you guys notice in that? And what I can do is I can slow it down as well. So this is as she steps on her right.
You know, she plants her right. Seems like her hip drops on the left.
Yeah, exactly. And what else do you guys see before she even starts to walk? What do you guys notice? What do you notice at the shoulders? What do you notice at the hip level, and what do you notice at the feet?
Play it again, remember. Just play it again.
So how about just standing here before she even walks? Can you guys see the screen?
Left lateral flexion of the thoracic spine too. The left shoulder's lower, right side's higher. And definitely a lot more compression of the left side, like you said, QL.
So that's the right side. I know it's a mess, man. Like I say, it's opposite, because if you look at the logo here, it's flipped.
Got it.
Yeah, so it's totally opposite of what you've said.
Wait, so left side is the right now?
Yeah. So it's basically, yeah, it's because this logo, you can see it should be saying head, but it's the other way around. So it's just the way it came on the computer.
But her shoulder too. One of her, my brain is messed right now. But her shoulder is uneven. One of them is up versus the other as well. Rib cage engagement as well, and one of the sides she's compressing her nerve on the kind of the fold.
Yeah, so that's a good point. So basically, on this side here, the shoulder's a little bit higher. That's one thing I noticed.
Wide hips, her Q angle is probably off too, because her knees are touching.
Yeah, so you can see the Q angle here versus here. She's got a bit more valgus on a little bit more of a little bit of a bigger Q angle on the left side here. And you could probably even see there's probably a little bit more eversion, calcaneal or eversion down here. Now what I'm going to do is I'm going to slow motion it. So as she steps, this is her right leg. That's the right leg, and this is the left leg as she lands. So one of the big things what we have to look at here is how her shock absorption, how well she's able to absorb that shock and stabilize the hip as she hits the ground. So you can see this is where the glute muscles should be engaging, but they're really not. Because you can see how that left hip is kicking right out. And so what I'm going to do now is go back to the case study. So same thing. So basically what I did was I took a picture of her essentially single leg standing while she's walking. So I took a frame of that video and I put it up here. So this is basically her on the right leg. So the stability, I mean, it's not bad. Once again, you can see that the shoulder here, this shoulder right here is elevated a little bit. But other than that, I mean, do you guys see any other issues that are going on when she's standing on the right leg? I should probably put left shoulder. Now we're going to go, this is the left, when she stands on the left leg. So once again, I took a frame out of that video and I screenshot it. As you can see, there's quite a bit of lateral shift. So essentially this hip is not very stable. There's no stability. It's Trendelenburg. And also what you can see is, if you guys can see this, there's a bit of pelvic rotation towards the right. Which what that does, it biases the hip flexors and the psoas muscle. And then what I did was I did a comparison. So look, you could see the difference even just looking at the pant line here. You can see a big difference in stability. Now, and this is probably about the time where you realize, well, maybe if you keep loading this patient and giving them exercises, it actually might make it worse because she has this pattern that she's developed over the years as a result of pain. So as you can see, this is probably why exercises and a lot of loading is probably not going to help her. It's just going to make things more and more sensitive and severely painful. And you also have to realize, depending on what the patient's job is, let's say if she's sitting for 8 hours, it's a little bit different than when she's standing for 8 hours, because she's already loaded up that area for 8 hours, and there's a lot of inflammation going on. And this is why doing a good observational assessment, even pulling out your phone, doing a video, doing like a slow motion, because there's a lot of things that you can catch in slow motion that you really cannot catch in it with a naked eye. There's no time for that. You can kind of rewind. You can see how the patient is stabilizing on that one hip, because that's the key. And this is where people will get in trouble, is this lack of stability. That's going to lead to other problems. And you can see also when she stands on this right leg, there's not as much compression here. Look at the level of compression there, which is why she's also going to have low back pain, which is what she came in for. But truly her problem is in the hip area. So now basically that's the easy part, is identifying now treatment. Anything else that you guys would like to add? Now let's try and figure out what kind of a treatment would you guys do on this patient ideally. So someone volunteer and just tell me kind of the steps as to what you would do with this type of a patient.
Calm down the trigger points first.
Yeah, so what would kind of be so calm down the trigger points. What kind of treatment options would you do for that? What kind of like modalities would you do to calm down the trigger points?
Get your elbows out.
Yeah, there you go. Get your elbows out.
Yeah, soft tissue, release, acupressure. And we can get shockwave on there, right guys? Maybe some homework, lacrosse ball work. But it seems like this is more of a motor control problem, like Milan's saying. She's had it for a while, and a lot of exercise is going to make her patterns even worse.
Yeah, too much exercise, especially loading that area. And the way she's loading it is very poor.
She's probably got a lot of compression in the lumbar spine too.
Yeah, exactly. Right here. I mean, you can see that. Whenever she loads that area, that hip kicks out, and there's so much compression right in there. Anything else that you guys would do?
No.
Anyone else? Jennifer, what would you do? Let's see if Jennifer's on.
Yes, I am. I guess with the compression in the vertebrae, I could do some passive intervertebral movements, like pivums, to try to do some localized segmental movement of each joint as well after releasing some of the trigger points.
So what would your kind of step-by-step action be with this patient? First 4 sessions, then afterwards, like, so just kind of run me through, because the problem is if I show you guys what I would do, then I don't get any feedback. I want to try to figure out what you guys would do in this case. And Jennifer, you're a good example to kind of tell us, because your mode of treatment is a little bit different. So I want to kind of hear what you would do and how you'd progress this patient. Let's say first 10 sessions.
First 10 sessions. Well, I think I would look at her innominate mobility, so how the right SI joint moves, and it looks to me it's anteriorly rotated. Like you said, the PSIS is sitting higher on the right side. So because she's anteriorly rotated, I would get on psoas, try to release the hip flexors to make sure she can get into a neutral kind of position with both SI joints being level. So passively get her into that position and then see if she can maintain it in standing. Give her some hip flexor stretches. Get her to bring that innominate, I guess, into posterior rotation on her own as homework. So doing like passive knee flexion, like the one-sided knee flexion, so that it's rotating the innominate posteriorly. And then the next session, as she comes back, to see if it's changed, and then see if she can engage the glute med better, because I think it's hard to engage glute med, like the abductors, if she has some rotation in there. And then I guess go from there, like having her activate the muscles first, and then see if she can get it in standing, and at the same time making sure she has a mobility in the lower back by doing the passive, doing the PSIS, checking the mobility through each joint, like from L3 to L5, and then making sure her QL is not tight, like see if there's any trigger points in the QL. Thoracic spine mobility I think is important, like doing thread the needle, and then scapular stability as well at some point.
That's a good point, Jennifer. Just check the thoracic mobility is a big one. Even shoulder mobility is huge, because your shoulder, that spiral line can affect your hip as well.
Now, in addition to this glute not working when she stands on this left leg, what other set of muscles do you think are not doing their job in this case?
Like transverse abdominis, I always look at that.
Exactly. So core muscles. So transverse abdominis needs to kick together with this gluteus medius in order to stabilize. Make sure that this leg is not going down and this hip is not kicking out. So it's a combination of those two muscles. And what I see for her is she's exclusively using her hip flexors to try and stabilize, and her ligaments and tendons. Anyone else? Any other input?
I think Cyril typed in hip or hamstrings. Hamstrings are a good one as well.
Yeah, hamstrings as well. So hamstring strength, yeah, so that's great. So assessing the hamstrings.
Adductors and glute medius, they all together. They work together. Synergists are there.
And another thing to add, guys, now if she's doing this for 5 years, you can imagine how these nerves are gonna be in this area here, in the lumbar spine. They're not gonna be functioning well. So, and as a result of that, guess what happens? You're getting that vicious cycle of these guys getting compressed, being angry. Well, guess what feeds the glute? What feeds the hamstring? What feeds the quads? It's the nerves coming from here. So as a result, that you get that vicious cycle where you're not getting that input from the nerves into the muscles. The muscles aren't working well because they're not getting that input from the nerves, and it just gets worse and worse quick. And that's why a lot of patients, as soon as they hit 60, they're getting their hips and knees replaced. But a lot of the time, the reason why that's happening is because there's biomechanical issues. That if they work out on those in time, they can avoid a lot of those surgeries. And the problem is, after surgeries, their biomechanics are still bad. And, in 10, 15 years, they start getting massive low back pain because they're having the same type of neural pattern. So same type of biomechanics. So that's why it's important to get on your patients. If you see something like this, get on them and just be serious about it. Because if you feel like this patient needs to come in for therapy, and you're convinced yourself, they're gonna come in. There's no other way. And if you show them on a video, it's like, look what's happening. Look at this side, look at this side. So that is the key. Like having these little videos makes a huge, huge difference. And at first it's not going to be natural for you, but as you do it more, it's just going to be more and more natural. So that's why I highly suggest that. So this was my mode of treatment here. So first few sessions, I exclusively just worked on trying to get the pain down. So I wasn't worried about, how her hip strength is. What I was really worried about, what I always kept checking after every session, is how her pain is at work. Because one thing you have to realize is that when a patient comes in and tells you, my pain is the worst when I do this, 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 that is going to be your measuring stick as to how your treatment's coming along. So always have parameters of pain measuring with ADLs. The 1 to 10 thing is fine, but people will notice when they don't have pain when they're sleeping, when they're able to sleep all night. They're gonna notice when they don't have pain when they're working. So these are first few sessions. I would try and focus on, like Parm said, is just work a lot on these trigger points and try to get the pain, kind of calm things down. Add a bit of stretching. Do some foam rolling lacrosse ball. But I wouldn't load these muscles a ton because she's already loading it, working 8 hours a day. So, and that's kind of what I would work on. Myself, I'm not really too concerned by the innominate and how the pelvis is and where, obviously I check that. But the reason why I'm not terribly concerned is because these are all the guys that are driving that innominate and that bone position. I mean, if these guys are imbalanced, then one's doing more work than the other. They're gonna push that bone that SI joint any way they want. And I can passively push that innominate in that position, but it's not gonna stay because then she's gonna go and work, and it's just gonna the pattern that she's developed because she's in pain is gonna come back because she's just gonna be in pain. When she's working, when she's standing, and she's gonna try to compensate for that pain. So that is kind of like what my thought is. So I exclusively try to focus on the muscles and try to make them happy. And then once they're out of pain, I want to slowly try to improve the muscle contraction. When I first saw her, when I got her side lying into that and try to get her abduct against gravity, there's really nothing, and I can feel it when I'm feeling it on the muscles to see what kind of contraction. There's not much contraction. So what I would do then is I would start working on retraining glutes. So retraining the glutes and the core as well. So trying to do the glutes and the core. I didn't mention core here, but I think core is very important. Non-weight bearing. So I would start with something that's non-weight bearing, that's easy for her to engage those muscles. And then also progress with stretching. Now here are some exercises. So for example, I would start maybe with this. So even with this, to get her just to get her to engage the hip muscles. So I would do something like that. Something like this for hip stretching, as much as she can tolerate. There's a ton of other ones. We can go down. As much as she can tolerate. And even getting her to strengthen her quads a little bit. And same thing with hamstring strengthening. So I would try and isolate, first little bit I would try to isolate the muscles. And then once the pain has calmed down, and keep reassessing the gait and also the pain levels at her work. If that's getting better, then you know you're kind of doing the right thing. And then continue with hands-on, then slowly progress to active rehab. After a few sessions, then what I would do is I would start with weight-bearing exercises. And I usually start with something that in their pattern that they're not really doing well. So for example, with her is trying to set that glute muscle, trying to set that hip in a certain way that the glutes will effectively function. So I would basically get her, so the first thing what I would do is once she's out of pain, once she's able to tolerate weight-bearing stuff, okay, what I would do is I would get her to
Go.
So just get her to do one of these. See how where the hip is quite a bit out? So laterally shifted. Essentially what she's doing when she stands on the left leg. And then get her to set. So that there's a little bit more alignment when she's loading that left hip and she's firing these muscles and obviously the core muscles at the front. And this is something you have to instruct her to do, instruct the patient to do, and get him to hold on to something because you're not practicing balance at this point. What we're trying to do is just engage this guy and this guy here. So try to engage the gluteus medius and try to engage the vastus medialis muscle. These two guys to fire simultaneously as well as the core and to stabilize this lower quadrant. And then and give this for homework. And then once she gets better at this, then you add, you can even do a little hip hike. And get her to hold on to something, just so then that way it's a little bit easier for her to feel those muscles working. And then you can even do this one after. Once she's able to set the hip joint in the right position, because how the brain works when it comes to firing muscles, your brain doesn't think, you don't actively think about, oh, I'm going to fire my glute med. The way that the brain gets that muscle to fire, the muscle gets to fire is if it's put in a certain position in space. Now, if your hip is out here, you're not going to be turning these guys on. They're going to be stretched. But when they're here, this is engaged and it's actually taking some of the load off the lower quadrant. So once she's able to do that, then you add different movements. So while she's stabilizing on this hip, you get her to move this other leg. But this leg has got to be stable. So you do something like that, and then you can even add a bit of like band work. Get her to push out, stabilize through this side, and then get her to push out with the left leg or the right leg, whichever one you want. So you kind of progress those. And then you even get into a little bit of squatting. But same thing, the whole time there needs to be stability here. So the hip shouldn't be kicking out at any time. So that's why taking a video and watching and making sure that there's good alignment is the key. Any questions so far? So the whole point of the exercise is to obviously do it pain-free. So she shouldn't be having a lot of pain when she's doing these exercises. She should only be feeling the muscles firing and working. And you also want to make sure that the patient's able to contract that muscle. So, last thing you want to do is put her on a Bosu ball and get her to try and engage her, glute muscles. It's just not going to work very well. So that's why make it simple, non-weight bearing stuff, make sure it's not painful. And then as she gets better, get her to weight-bearing exercises, and get her to feel those muscles contracting, which means making it a controlled environment. And once she gets better at that, then you kind of make things a little bit more complicated and a little bit tougher. And then the single leg stance retraining is key. And I would include that into your exercises and as well as your testing. Now, one thing I've noticed is that patients, when they do have hip arthritis, they might not be able to tolerate some of those positions because the hip joint is already just too far gone, and they're not able to, as soon as they try to bring that hip in, they start getting pain. Now, this is probably severe arthritis. With mild and moderate, it's not the case, but I've seen it with severe. When I do try to get them to engage or bring that hip in and stabilize with the muscles, they start to get pain, quite a bit of pain. But that also could be because they have trigger points, still have trigger points in the gluteus muscle. So basically, that's how I would approach this this patient. Do you guys have any other questions? Anything that you would add to this treatment that I don't have? And then lastly, what you need to explain to a patient like this is explain to them that their body is not designed to stand for 8 hours. Thereby, they need to keep up with their foam rolling, lacrosse ball, strengthening exercises. They need to do it as a maintenance form. And even getting therapy on a regular basis, because they're putting their body through a lot of stress with standing for 8 hours. These exercises will help and strengthen things. But at the same time, they have to realize that it's not something that, they can just, do a couple sessions and it's going to be fixed and it's going to be cured. It really doesn't work like that. And once again, the whole point of the exercises is so that when she does walk and stand at work, over time, the more she does those exercises and the more she engages the right muscles and the right muscle pattern, she's going to start doing that automatically without even thinking about it. And that is the goal, to try and get her to engage those muscles so that she's not getting into this position, that she's tucking that hip in, engaging the core, and she's able to stabilize that hip joint. Because then she's going to get a lot less wear and tear on the hip joint, and the muscles are going to be working more. And she's going to get better alignment through the back because this is a ticking time bomb. Good.